Thanks for the kind introduction, and very happy to be here. So I'm going to be talking about GLP-1s, and you can't really move without hearing something about GLP-1s in some context. So I'm going to be focusing, though, on the elderly patient, because it is a really important area, and it's an area, as we'll find out, that there's not as much data as there should be. So here are my disclosures. So I'm going to jump in, before I jump in, I'll talk about my key questions. So the first two are really hand in hand. Do GLP-1s work any differently in older populations, and are the risks any different? The second is focusing on one potential specific problem, and that's lean mass and physical function, and what are the implications for the older patient. And then I'll end by talking about potential impacts on biologic aging of these agents. So incretins. So incretins are hormones that are secreted by endocrine cells in the gut. So GLP-1 is secreted by the L cells in the large bowel. The GIP is another incretin that's secreted by L cells or K cells in the duodenum. So with a meal stimulus, you get insulin, you get release of these agents from the gut, and they have a bunch of different sites. Here it shows that they're acting mostly on the pancreas. So their effect on glucose metabolism is glucose dependent. So glucose increases and insulin will be released from beta cells. And that glucose dependency is really important because the insulin won't be released unless the glucose is high. And so these drugs don't cause hypoglycemia when used in patients with diabetes, and importantly, they don't cause hypoglycemia in people without diabetes. And so they have a good safety profile and can be used for a wider group of people. They also have, or GLP-1 has an effect on alpha cells in the pancreas, which secrete glucagon, decreasing glucagon production, which has downstream effect on the liver. And so endogenous GLP-1 and GIP are metabolized really quite quickly, within seconds, by an enzyme called DPP-4. And DPP-4, inhibitor of DPP-4 is these are gliptin class, like sitagliptin, that we use in diabetes. So by inhibiting DPP-4, you get elevated endogenous levels of GLP-1 and GIP, and that's how they have their glucose lowering effect. Now, the medications that are used that I'll be talking about are receptor agonists and are not broken down by DPP-4, so they last a long time, like a week, and that's how we dose these drugs. So GLP-1 receptors are in lots of different tissues. I talked about the pancreas. The pancreas, but also importantly in the stomach, slowing gastric emptying, decreasing nutrient absorption across the gut. A really important effect in the brain and the hypothalamus to increase satiety and decreasing food intake. Effects on the liver, decreasing hepatic steatosis. And then a bunch of other organs that are super important, like the heart and the kidney. They have specific effects. And specifically in our population on immune cells and white adipose and brown adipose tissue, and some effects on skeletal muscle as well. So these drugs are really approved for two different reasons in two different patient populations, people with diabetes and obese people without diabetes. And so on the left you see the approved drugs for diabetes, and exenatide was the first drug in this class, and tirzepatide is a dual agonist, or it works as a receptor agonist for both GLP-1 and GIP. And you can see that the glucose lowering effect, and this is the number of the hemoglobin A1C that it decreases by at the highest dose, it increases as with newer generations of these drugs. And the weight effect also increases, and pretty profound weight decreases. It's notable. In obesity, we have three drugs that are approved: liraglutide, semaglutide, and tirzepatide. And you can see these weight decreases that you get, which is rivaling what you get with bariatric surgery. So there's a lot of enthusiasm about these drugs, both on the diabetes side and on the obesity side, and that's why we have GLP-RA mania right now. So there are some other approved indications, and this I would argue is why diabetologists are really excited about these drugs, in that we have drugs that lower glucose, no problem there. It's nice that they decrease weight, but what's really key about these drugs is that they decrease cardiovascular events. So cardiovascular events are what kill people with diabetes, and so we have an agent that actually decreases these events with good quality data to show that. And so these are the other FDA-approved indications, so decreasing cardiovascular risk for diabetes. So for dulaglutide and semaglutide, the tirzepatide trial is still ongoing. Those results haven't been reported out yet. These drugs, or at least semaglutide, also decreases cardiovascular events in people with pre-existing cardiovascular disease, but without diabetes, who also have obesity, and that's the SELECT trial, which I'll be talking about. There's also an indication for semaglutide for renal function preservation based on a large clinical trial, and an indication for semaglutide for steatohepatitis, and for tirzepatide for obstructive sleep apnea. So that's where we are with the FDA-approved indications. Now, there's a lot of interest in these drugs, and for a lot of different reasons. And so one of them is diabetes prevention. These drugs do prevent diabetes, but whether or not they'll get a recommendation or an indication for them is unclear. They do decrease systemic and adipose inflammation, decrease heart failure. And then there are some other uses which are really quite interesting. We were just talking about a methamphetamine study that Scott's thinking about. So substance use disorders, alcohol use disorders, neurocognitive disorders. There's lots of interest in these drugs for various indications. They are not without their problems. The GI toxicities are the ones that are most common, treatment limiting in about 10% of cases with nausea and diarrhea. That's why we start at a low dose and go up very slowly. There's other GI issues like pancreatitis and bowel obstruction and gastroparesis, which are relatively rare. I'll talk more about the muscle mass issue. With the fat loss in the face, you can get facial lipoatrophy, also known as Ozempic face. And then there are other potential things that have been reported, but I put question marks next to them because they haven't really been proven, beyond a reasonable doubt. But there's a lot of research going in now that we have lots of people on these drugs. It's really important to look at the safety signals that come out. So for my two first questions about older populations, risks, and differential efficacy. So the nice thing is that the FDA actually helped me on this. So I was trying to figure out, okay, what about these drugs in older populations? So if you don't know, if you about the package inserts, there's a section 8 on the package insert of the FDA, and it's all about special populations. And the 8.5 in every package insert is about geriatric use. So the FDA looks at all the clinical trials and looks at older populations and see if there's any differential signal in older people versus younger people, both signal in terms of efficacy or signal in terms of risks. And so I put together all of these package inserts, the information from the package inserts, and it's split up into diabetes and obesity and the various drugs. And so the trials, so these drugs, as I mentioned, some of the trials were related to glucose outcomes. Some of them are cardiovascular outcome trials to show that they do have cardiovascular efficacy or to test that hypothesis. And then there were some others in terms of MASH and OSA. So the first thing that I'll note, if you look at the percentage of the populations that are that participated in the studies, there's a lot of heterogeneity between these trials. So for the glucose-lowering obesity, these are younger populations, and so there are actually quite few people that are 65 and older. For the cardiovascular outcome trials, these are people with pre-existing heart disease, so they're older, and you can see the higher percentages there. But if you look at the next column on the right, with the population 75 and older, what you see is that the numbers are really, really small, single-digit percentages. And so the first take-home message is we actually know relatively little about these drugs in older people and people over 75. So I think that's a really important take-home message. So in general, how the package inserts conclude is that there are no overall differences or safety and effectiveness of whatever drug it is have been observed between patients 65 and older or younger adult patients. There are two exceptions that are worth talking about. The one is and it's both for people with obesity and cardiovascular disease from the SELECT trial. So this was a large study, 18,000 people around the world, people without diabetes who are obese and have pre-existing heart disease, stroke, or peripheral vascular disease. So the first thing they said is they said that the older individuals had more serious events who are randomized to semaglutide versus placebo. And so I'll show you the semaglutide result. This is the New England Journal paper from a couple of years ago, showing that there was about a 20% reduction in their MACE endpoint, their cardiac endpoint, with semaglutide versus placebo. And there was also a significant effect at their heart failure endpoint as well. So great. So what about the toxicity? So you dig into another paper and you start looking at the toxicity. So these are serious adverse events. This generally means either death or hospitalization. And so a few things that I wanted to point out, and I overlaid a bigger font so people could maybe see it in the back, but I think that's going to be a challenge anyway. So the first two lines, so cardiac disorders. So the black is semaglutide, the triangle, the gray triangle is the placebo, and this is the number of events in each of these age groups. And as you'd expect, the overall these events increase with increasing age because older people have more events. But what you'd expect with cardiac disorders is that the black box is on the left of the triangle. So this shows what I just showed you with the cardiovascular. This next thing is actually it was a surprise to me, and I haven't heard too much about it. This is infections resulting in hospitalizations. And apparently this was mostly bacterial pneumonia and COVID pneumonia, because this was done during the pandemic. But look at the difference between the black box and the gray triangle in the 75 and older. So it looked like there was a protective effect in that age group for infection, which is really pretty interesting. But what I think that the FDA was looking at is the other thing that I highlighted. It says GI disorders, and you can see the black box is on the right side of the triangle. So relatively few events, but maybe if you squint your eyes, there's some signal there. Go through here. Okay. The second thing that came out that the FDA noticed was that there were more fractures of the hip and pelvis in those randomized to semaglutide versus placebo. And so again, this paper was really instructive. You could dig into the paper and look at these events. So here's the rate of hip and pelvis fracture per 100 persons by age. So of course, fractures increase with increasing age. And you can see semaglutide versus placebo. And that the big difference in that older age group with 20 fractures versus 4 fractures I think is what the FDA is getting at. So what about the bone effects of these drugs? What's going on here? And so this is an area where we need a lot more research. And so this is a paper from Osteoporosis International from earlier this year, and I blew this part up. They start to review a little some things. There are some animal studies, but there are really very few studies that either look at fracture or look at bone mineral density on these drugs. And so we know that bone mineral density will decrease with caloric restriction and with weight loss, but whether there's an added effect of GLP-1s is another thing that really needs to be investigated. So this is an interesting trial, and this ties into the session and what Christine is going to talk about too. This is one of the only bone mineral density studies that we have. So this was people with obesity who initially got a very low calorie diet, 800 calories a day for 8 weeks. And you can see on the left, the panel with the body weight, the body weight dropped like a stone. And then they were randomized to either placebo, exercise, liraglutide, which is a relatively mild GLP-1. and exercise plus liraglutide. And so what you see is that, once the low-calorie diet stopped, you can see the placebo sort of goes back to baseline. But the group that actually lost the most weight was those who got exercise and liraglutide next in the black. So you have that on the left panel, and then on the right, you have the change in hip bone mineral density. So the bone mineral density takes a hit with the very low-calorie diet, as you might expect. But the biggest loser here of bone mineral density was the liraglutide arm. Whereas their liraglutide plus exercise was a little bit less, suggesting that the exercise actually attenuated the liraglutide-related bone loss. So, I think that this is an important trial to also understand that exercise could be an important way to mitigate some of these side effects. So the other part of this, in addition to decreases in bone mineral density, you get decreases in lean mass. And so all of the trials have shown a decrease in lean mass. And the big debate is to what extent is this clinically significant? And is this out of proportion to what you'd expect? The bottom graph, what is shown is the percent lean mass loss versus the percent body weight loss with diet, with GLP-1s, and with bariatric surgery. And what this shows is that basically you have the same relationship here. You lose fat mass, you lose lean mass. And there's not really an outlier here with GLP-1s. And we still don't have a great idea of whether or not this is clinically a problem. What's more important is muscle function rather than muscle mass. What we don't know is that in older populations, this loss of muscle mass may have a different significance that we just don't know about. We do know something about people with HIV. So this is the SLIM liver study led by Christine and Jordan Lake. So this was a study through the ACTG looking at decreases in liver fat in people on suppressive heart with liver steatosis and central adiposity who got up to 1 milligram of semaglutide. So this is the body composition. There was an average loss of about 7.8 kilos over this time period. Well, what about the muscle? And what about muscle function? And so this is a nice study that Grace Kulik, Ditzenberger, published earlier this year, showing that there was a decrease in psoas volume, and that decrease in psoas volume was actually most pronounced in those that are older than 60. And there was a suggestion that there was a decrease in the fat in the psoas, but this was not statistically significant. So you think, oh, there's a decrease in muscle mass. Well, what about muscle function? Did muscle function take a hit too? And the answer is no. And so chair rises that Peter was talking about earlier, 5 chair rises, 10 chair rises, gait speed. Not only did these not decrease, but they actually trended towards improvement. And so here, this is a really important distinction that between muscle mass and muscle function that I think we're going to need to get both measurements as we do more of these studies and start to understand things a little bit better. So how do you prevent this? So there's been some nice nutrition articles about it. So resistance training does help, and we'll hear more about that from Christine in the next section. People recommend increased protein intake. And these recommendations, of course, have been commercialized. So you can see lots of different strategies to do this that people want to make money from. There are also some pharmacologic strategies that are coming down the pike. So this study was presented at the American Diabetes Association earlier in the summer. And this looks at a drug called bimagrumab, which is a receptor blocker to the activin receptor in muscle. So myostatin and activin A bind to the activin receptor, and it leads to muscle wasting and cachexia. So this blocks that receptor, and so you get reversal of the wasting and improved muscle mass. And so this is given IV, so it's an IV infusion, and the patients got semaglutide at the same time versus semaglutide alone. And lo and behold, the people who got the combination therapy lost the fat mass, but not the lean mass. So this is sort of, it's not ready for the clinic yet, but this is proof of concept that this dual strategy may be helpful, at least for weight. Whether it improves physical function and whether it helps people in the long term is another question entirely. So the last thing I wanted to talk about is the impact on biologic aging. And so we've all seen these hallmarks of aging. These are the underlying potential mechanisms that drive many of the aging processes, and I won't go through them in detail. But there's a lot of interest in whether or not GLP-1s can impact these specific mechanisms. One of them is mitochondrial function, and this is actually a very nice review from this year, looking at these studies, and the conclusion was that that GLP-1s can impact mitochondrial morphology, genes that regulate mitochondrial biogenesis, mitochondrial function. The downside is that there are 0 human studies, and so we really need to be thinking about mitochondria in people. Mice are interesting, but it's not enough. There are lots of other tantalizing articles like this. Can we turn back the clock with GLP-1s? And the answer is, yeah, maybe. We need to look at it. And it's really, we're at a period now where there's interesting animal data, but not with humans. There is, some human data. This is actually in HIV. This is a nice study that Alison Eckhart and Grace McComsey did, looking at people with central fat accumulation with HIV, randomizing them to semaglutide or placebo, showing about a 30% loss in visceral adipose tissue, about a 5.7 loss in lean mass, 10% loss in body weight. And there were significant decreases in some inflammatory markers that didn't appear to be related to the fat mass that was lost. And so inflammation, of course, it may be a driver, may be an underlying pillar of aging. But what I wanted to show you in particular was a study that was presented at CROI by Michael Corley, looking at the epigenetic clock. So at baseline, the people in this study had advanced aging based on various epigenetic clocks. And you can see these differences in the change in the epigenetic age in the placebo versus semaglutide, showing that semaglutide could either improve epigenetic aging or stabilize that aging versus placebo. So whether or not this is tantamount to reversing aging, biologic aging, probably not. I think that whether the epigenetic age is really a causal mechanism is still under debate, but it is quite intriguing. So I'll end with the unanswered questions regarding the use of GLP-1s, and they're basically the questions that I started out with. So there's a lot that's unanswered. Regarding long-term safety and efficacy, there's a lot of questions regarding the role of the dose. Which dose is the right dose? How long should people be treated? What specific agent should we use? What happens after you stop these drugs? All this is really important. What do we do about the bone and muscle changes? Are they clinically significant, especially in older population? What should we do in the meantime besides diet, protein intake, and exercise? And relating to their effects on biologic aging, there's a question about how much is this related to weight loss or changes in glucose metabolism versus direct effects. So I will end here. Thanks.
Yeah.